in my talk, I'm going to talk about a slight debate between the trifocal and the EDOF, and which we are going to use. So I have no financial disclosure about my presentation regarding any of the brands I want to talk about. These are my financial disclosure. As we all know that cataract is one of the leading cause of vision impairment. So our goal is to restore vision. This was in the past. But now we are going to do a cataract surgery with a refractive procedure. And like this, also we are offering to the patient an optical spectacle independence. So we are going to in the era of multifocal or EDOF, which is a different foci, either it's a refractive or a diffractive optics. When it started by the EDOF lenses, which is increased range of focus. EDOF for sure give a clear vision ranging from the up to intermediate distance, like the computer monitoring. It's very good for the close activities. But most of the EDOF, we need wearing to wear reading glasses because it's not good as we're going to see for near. So it's bending the light. This is how the EDOF is working, and it is mainly good for intermediate and distant vision. If we are going to talk about different lenses, so the insufficient intermediate vision, which is offered by some lenses, the EDOF make it more good. And when there is a trifocal lenses, so it is subsequently introduced offering a third focal point. In an attempt to achieve a good quality of vision in all distances while avoiding the undesirable photopic phenomena, a new generation of the new EDOF lenses appeared in the market. And the EDOF technology is based on the elongation of the distance. The eye remains in focus, thus aiming to provide uninterrupted range of focus. So in this table, we are going to see how the three lenses, which is the bifocal first, the trifocal and the EDOF. So the EDOF give the intermediate the best, less than the trifocal. But in the reading performance, we are in the near vision, we are going to have that the EDOF is less than the trifocal technology. But when it comes to contrast sensitivity, the EDOF is above the trifocal. We are going to talk about, when we are going to talk about EDOF and trifocal, we need 5 points for differentiation. The quality of intermediate and near, the defocus curve, the contrast sensitivity, the reading performance, and the optical phenomena. So we start by the quality of intermediate and near vision. Trifocal were developed in order to eliminate the quality of intermediate vision through the incorporation of the third focal point that bifocal IOLs in the past lacked. So several studies investigated whether implanting a trifocal held its promise to improve the intermediate vision compared to the EDOF lens. Most of the studies say that the visual outcome for the intermediate vision is concerned for the trifocal lenses. Unfortunately, there is no international agreement because we are highlight the importance of luminosity for the intermediate and near. So we are measuring the intermediate and near by the luminosity measurement. But most of the international agreement on the luminosity setting, unfortunately, there are no such rules for to have it accuracy in the conclusion. And since there is numerous studies have been concluded comparing the EDOF lenses mainly to trifocal IOLs more than the bifocal, which is decreasing nowadays. And the Technic Symphony was the first EDOF labeled IOL approved in the US in 2016. If we are going to talk about the quality for intermediate and near, so the EDOF lenses exhibit similar results in terms of distant vision when compared to trifocal and bifocal. And also, if you are going to have similar results on corrected distant vision after implantation of trifocal, like the Atrelisa or the Panoptics from Acrysoft, studies say that in the terms of visual outcome and contrast sensitivity, and the investigator reported that the mini-well EDOF IOL has similar uncorrected distant vision outcomes to the previous studies for the multifocal. Very important to know that in the photopic conditions, where there is no statistical significant difference in the uncorrected intermediate vision outcomes between the EDOF and the trifocal, thus it seems that the illumination settings may play a crucial role in the performance of each IOL type when intermediate vision is concerned. We must also know that both the EDOF and the trifocal achieve spectacle independence for intermediate and distant vision. But in terms of near vision, the trifocal is over the superiority to the EDOF lenses. But you must know that still the level of post-operative satisfaction was the same in both patient groups in most of the studies. The second point is the defocus curve. The most aggressive defocus curve was the bifocal curve, which is the V-shaped defocus curve, like this. As we see in this graph, the blue one is the defocus curve, the bifocal, which is the graph represents the defocus. It's high V-shaped in the bifocal, but it's very smooth in the EDOF and less V in the trifocal. And we are going to see that. So the defocus curve show it's a significant better visual acuity in eyes implanted with a trifocal IOLs for a defocus of -1 to -2, which is corresponding to the visual distance from 1 meter to 50 centimeters. And several additional studies agreed with this results, with the meta-analysis of Chen et al. Concluding that the trifocal IOLs achieved a better results at a defocus of -1.5 to -0.5. And this presents significantly better intermediate vision when compared to the bifocal. But the defocus curve, the EDOF, produce a smooth, uninterrupted, and dome-shaped like defocus curve, which provide a good quality intermediate vision and tapers off at the reading distance. So not surprising that the EDOF provide a better vision at -1 and -1.5 diopter defocus compared to the bifocal. Then the trifocal, which give a best at -2 to -4 defocus between 50 and 25 centimeters. But this depends on important note that the multifocal and the EDOF IOL's performance has also been shown to depend on the pupil size. And we must know that the EDOF IOLs provide the best vision at 2 millimeter pupil size. But the trifocal shows better pupil independence than both bifocal and the EDOF IOLs. What about contrast sensitivity? There is a superiority of the EDOF over the trifocal IOL in terms of contrast sensitivity due to the compensation of the chromatic spherical aberration by the EDOF IOL design. Minkuri said that confirmed this hypothesis and demonstrated that the EDOF thickness symphony is associated with enhanced contrast sensitivity under both photopic and mesopic conditions when compared to trifocal like the Atrelisa or the Panoptix. And also, there is a comparison involved between the EDOF and the bifocal lenses, and there is absolutely no statistical difference in the term of contrast sensitivity. What about the reading performance? Several methods, such as the Randall, the Strasberg reading chart, the calculation of the maximum reading speed, the critical print size, have been used to assess the effect of various IOL typing and reading ability. But this is a complex procedure. You cannot guarantee if this will going to be a good or no, because it depends on the good attention span and negative function. Thus, the result of the reading ability assessment should be interpreted with caution. And moreover, the distant concern of maximum reading speed, distant corrected critical print size, also exhibited to no statistically significant difference between the two groups. Also, some studies said that the enhanced contrast sensitivity of the EDOF lenses possibly compensate for the worse near vision for these lenses. What about the optical phenomena? The design of the multifocal is based on the division of the light into different foci. So an important aspect that the multifocal and the EDOF IOL implantation is the occurrence of undesired optical phenomena, which may compromise the quality of vision. Either it's halos, flashes, starbursts, glares, shadows. So but you must know also that the evaluation of the optical phenomena varies across different studies, which makes the valid comparison of different IOLs almost impossible to make. The frequency of all the aforementioned phenomena decreases as time goes, and it is likely due to neuroadaptation. And the comparison between the EDOF and trifocal showed no difference in the dysphotopic phenomena in the most of the studies. And less than 1% of the patients experienced symptoms, and those who did, very few reported disturbance of their everyday life. So when we come to the conclusion, it's either GIF or JEF. How? Over the last 10 years, newer IOL technology has revolutionized cataract surgery so that the rising patient expectation of excellent distance, intermediate, and near vision can be met. But the most important, the choice of the IOL should depend on each patient need after through questionnaire about their work and daily habits. And the main IOL type that have been developed include bifocal, trifocal, and EDOF IOL. And in general, the trifocal IOLs enhance the intermediate vision in comparison to the bifocal IOLs due to the addition of third focal point. And the lenses provide better contrast.
Dr. Ashraf, the net is not good with you.
Intermediate, but we need near vision. However, the EDOF lenses are inferior. So this is the last thing, and this is my take-home message. Yeah. Remember the critical importance of carefully selecting and matching your patients to the most appropriate IOL. Don't skimp on time, and make sure you choose patients with
Dr. Ashraf,
psychological.
we are not hearing you well, Dr. Ashraf. We are not hearing you well, yes. Because I think that the net. Anyway, we are crossing the time. The time for the discussion, we are across it in this presentation, so I'm very sorry that we need to summarize the issues. Now, the second presentation, if we don't mind, we can go to Dr. Osama. Great, thanks, Dr. Ashraf. It was a very nice presentation. I had a few questions for you, but unfortunately, the time is taken for the discussion. So we invite here. I would like to invite Dr. Osama Jaledi, and Dr. Osama Jaledi, if he is here.
Yeah,
Dr.
can you hear me now?
Okay, yeah, I can hear you.
Is my screen on?
No, we are not seeing your screen. Now, ICL versus Artisan for myopic patient. The time here is taken 15 minutes. So the time that we start around 2-3 minutes late. So that's why now it's 5:16, because Dr. Mazen was mentioned. Mazen here with us? Mazen? Dr. Mazen?
Yes, I am with you, dear.
Yeah, Dr. Mazen, he was mentioned that we are crossing the time. No, we didn't. It was the 5:15, and that's the 15 minutes given to Dr. Ashraf Armian. Okay, Dr. Osama.
Can you see my screen?
Just start, please.
Can you see my screen, Safwan?
Yes, now I'm seeing your screen. Please.
So basically, I'm talking about ICL versus RC clip for myopic patient. Is it screen moving?
Yes, moving.
So
go ahead.
Basically, both phakic implant, as you know, is very good, ideal for high refractive error. because they have predictability, stability of refraction, you reserve the accommodation, but also they have a very good, excellent quality of vision, and many patients gain vision instead of the laser vision correction for people with high myopia and hyperopia. As you know, when we have a patient for phakic implant, it's very important to have few measurements to have the included criteria. Anterior chamber depth is very important. Patient should have endothelium, healthy endothelium, iris shape, configuration, and the pupil size. All we need to measure it because that will decide which the best lens for this patient. Anterior chamber depth is very crucial for all phakic implant and should be measured in the central. It should be more than 2.8 from the endothelium size to the natural lens. There's another things for anterior chamber implant, which is the distance from the iris clip to the endothelium. They call what they call critical distance. That's very important for iris claw implant. It should be at least more than 1.5 millimeter. But however, for that one is not important for ICL. As you know, measurement of the anterior chamber depth is very important. Usually, A scan is not useful, but Orbiscan, Schimfleck, OCT, UBM, all they have very good way to measure the anterior chamber depth. The other measurement, we need to measure what we call angle to angle, which is really important for AC phakic implant, which is most of the phakic implant you see, we stop using it because of the problem. But sulcus to sulcus is very important for ICL implant. One thing's advantage for iris clip, it's that which is the major disadvantage in it, that one size fits all. So you don't have to worry about the sizing of the implant for iris clip implant. However, when the patient had like convex iris clip implant, they may be not the best option for a patient to have a convex iris because that will make the lens very close to the endothelium. The other measurement which we use for what you call AC size, this is very important for ICL implant because really the size of the implant is very crucial. And there's different way we measure the AC or white to white distance. The standard way is what you call caliber, and still the golden standard, but a lot of a newer way to measure better. Benteca Orbiscan, another measurement. IOLMaster tends to be not as reliable. But UBM, if you had access to UBM, that's the best option to measure sulcus to sulcus. And that will be very helpful, especially with the newer UBM technology. That will help because one of the problems with the ICL before is the sizing can be a problem. As you know, endothelium is very crucial because we implanted this lenses inside the eyes. So you should have a good endothelium count to start with, more than 2,200 for both implant. And you measure 3 monthly, but after that annually. The only thing is very crucial that if the endothelium sound drop down, you need to explant this implant. And that's very crucial really for patients who had anterior chamber implant because there's more close endothelium and you could, patient may lose the follow-ups and come with decompensated cornea. So anyone had anterior chamber implant, artisan, that's when you need to explain to the patient that annually monitor is very important. However, in ICL, is important, but not as crucial because it's a bit far away from the endothelium. As I mentioned, angle supported implant really because they have problem with pupil decentration, iris atrophy, and long-standing endothelium loss. They come in the market and after that they disappear. So no available angle support implant at this stage of time. Regarding iris claw implant, it's available a foldable or non-foldable, artisan, which have 2 sizes, 5 and 6, or Artiflex. As I mentioned, it's one size fit all because it's clicked to the iris, so you don't worry about the size itself. So you're just looking for the power of implant. 5 millimeters have a wider range, and they have also astigmatic correction. And 6 millimeter, it's lesser for, is mainly for myopia. But this implant, you need to do peripheral dotomy for this 2 type of implant. Artiflex, the advantage because it's folded optics, so you could go through the smaller incision. Always they say if you had decentration of the implant, which is one of the major disadvantages of the iris clip, is really the surgeon fault. It's not the implant fault. So always they blame the surgeon for that. But one thing I noticed that the problem with this lens is with the long time, it eroded through the iris and it could be subluxated or lose the grabbing. And you have few patients coming to me with dislocated lens and they have damage to some of the endothelium. So really, and also if they do any active sport, there's lenses is not as good for people who do active sport. Also, people can have iris, IOL, what you call pigment deposition, because rubbing more in the iris, and they may need steroid treatment for long, or maybe you need to have surgical manipulation to do it. Another way, the posterior chamber implant is nowadays we have 2 ICL, which is the most common one, but IBCL, this is the Indian version of ICL. The advantage of it, you could through its small incision, is far away from the endothelium, but the major disadvantage really, because you put it closer to the lens, that can technically causing cataract. The ICL is, they have special polymer, which is really tested for many years. So the ICL almost 30 years now in the market. So it's a very, very well polymer, very adapted to, and there's no side effect of it. It's cover all range myopia, hyperopia, astigmatism, but the sizing is very crucial for these lenses. The surgery is very simple, although loading the ICL, I think the challenging part to loading the ICL. Always you need to have a spare one in case it's damaged is better. People after surgery, as I mentioned, is very simple, but really very crucial to be very gentle in the surgery. And the good things with the new design, you don't need to do iris peripherotomy, because the V4C, they have a hole in the center, and that one really helped make the surgery much easier, but also allow the circulation better. And that technically people reported that by this technology, that may be reducing risk of even the cataract formation, because the flow of the aqueous is better, and that will help reduce the risk of cataract than the one reported before. Sizing, as I say, is very crucial. If it's a smaller size, you have more decentration, and that's close to the lens cause cataract. If it's bigger, the angle vaulted forward and the angle closed, and that causes glaucoma. So the sizing is very crucial. If you have the right sizing, really, that will expect it to have very good result long term. But if you had short-sighted or manipulation, patient they could develop anterior subcapsular cataract. Some of them, they will have a mild one, is stable, and not worry about it. But if a progressive, you need to do cataract surgery. IBCL, as I mentioned, this is the Indian version of ICL. I haven't had much experience about it. They have four holes, and people reported they have a good result of this type, but I don't have personal experience. So compare all the lenses together, all of them, they have a good range of myopic cover, hyperopic cover, and astigmatism. Regarding anterior chamber depth, for ICL, I think 2.5, Artisan, Artiflex, Artisan, they said 2.8, but I think really it's better to have 3 millimeter for both of them. The crucial white to white and sulcus is very important for ICL. Iris configuration, as I mentioned, you need to avoid it if someone had convex iris to put Artisan or Artiflex, but it's not important for ICL. Pupil size is very crucial for Artisan, especially. It's less crucial for ICL. And endothelium size is important. Regarding the pupil, you need to have a good dilated pupil for ICL. Otherwise, you had more manipulation, you had more risk. Incision, usually ICL is the smallest one, 3.2. Artiflex, they said 3.2, but I think usually you need more dilated than that. But really very crucial, this ICL with the hole, to avoid BI. As you know, peripherotomy surgically by itself, even for acute glaucoma before prophylactic, it can cause cataract. So by avoiding BI, it makes the surgery much easier. So compare iris claw and ICL, really surgery is much easier with ICL. It's much easy. Endothelium damage is much less, especially if the patient you think is not going to regular follow-up. ICL is a better option for this patient, but in the prices, you could risk of cataract. Glaucoma is much less in ICL than ICL if it's good centration. Rotation is an issue with toric ICL, but as you know, ICL is a good thing. There's no rotation, and the size is more crucial for both. Regarding the BI, as I mentioned, is you don't need it for the new ICL, which make the surgery easy, but it's also better, less trauma. Centration, ICL is better centration. The problem with the ICL, iris claw, any decentration will have a quality vision. Some people reported that they have more high order aberration in patients who had iris claw IOL because they're slightly decentration.
Need regular follow-up. 4 minutes left. I think that you crossed the discussion, please.
No, it's okay. The cost is really is the more expensive ICL, cheaper ICL, and you don't need. The studies show really the vision result is very, most of the studies show very close to each other. So both they have a good result regarding the vision. One thing is the new ICL, there's a presbyopic lens available now, which can give you advantage of ICL for patient who is above 40 up till 50. So all phakic implants give a good refractive result. There's more chance to gain vision. The key for phakic implant is that's a refractive stability, but this can be have long-term refraction complication. ICL is much easy surgery. ICL is easy and need less experience from the surgeon. Iris-Clo is cheaper, and you could fit it with, and you had easy to have a stock. Personally, I prefer ICL than Iris-Clo, and thank you very much.
Great, thanks, Dr. Osama. It was on the time, and we have now 3 minutes only for discussion. Is there any question for Dr. Osama? I had a question to Dr. Ashraf. If there's no question to Dr. Osama, and then we will start with the Zina Al-Muhtasib.
There's one question in the panel, by the way, there.
Yeah.
They're talking about the iris fixation for retrobubulary artisan. We're talking about normal patient with myopia, not talking about a phakic patient here, okay?
Yes, exactly. So, Dr. Ashraf, only one question. We have 2 minutes. The question is that those that they are not eligible for trifocal, you will be able to put an EDOF for those patients, and in those patients, if you will modify or manipulate the
I treat
1 minute, Dr. Ashraf. I didn't finish the question. If those patients they need a reading or in EDOF lens, can you manipulate the refractive residual in a way that you can enhance the near vision? Thank you. Yes, Ashraf.
Yes, if they are dependent on the reading and the daily activities reading in the most, I'm not going to use EDOF lenses. I'm going to put a trifocal, because trifocal and the EDOF for me is the same premium. And what I do for a trifocal, if it is the dry eye, if it's the macula, if it is anything EDOF, it is going to prevent trifocal. But the activities, it is the mark when to choose EDOF.
Unfortunately, the net is not helping us between us and Ashraf.
Safwan, can you ask a panelist which their favorite, Artisan or ICL? All the panelists, please.
Well, starting from me, ICL, and I don't like the Artisan. In spite of that, I'm doing it in certain cases.
That's fine.
And I don't know whether Dr. Mazen or Dr. Ashraf they have any issues with it, or Zina, she has any issues with the Artisan.
In the US we only have the ICL, so Iris-Clo is not even an option for us. So that's an easy answer for me.
Okay. Mazen?
Yeah, the ICL, it is the only option for me. Of course, I don't go for Artisan because I have, I know about the complications of Artisan.
Okay.
Okay, Dr. Ashraf?
Ashraf, I think that now we need to close this session and return back to Zina. Zina Al-Muhtasib, she will give us a toric lens versus monofocal lens for astigmatism cataract correction. Actually, we have a lot of questions, and this session have a lot of discussion to be, but we don't have a time. And whatever we are giving and try to reduce, but the time is with us. So Zina, let us, Zina, show us how she will use or why she's using toric instead of monofocal. Zina, you are mute, Zina.
Okay, sorry about that.
That's okay. Done.
Again, thank you for the opportunity to present. And I got an easy one. I don't think it's really toric IOLs versus monofocal lenses. So I'm going to concentrate a little bit on which patients I do toric IOLs. Astigmatism management and cataract surgery is so important because of the increasing patient expectations. And about 15 to 20% of patients have more than 1.5 diopters. And a lot of them, a large proportion of these patients have lower magnitudes of astigmatism. So I'm pretty aggressive with treating astigmatism, even as low as 0.8 diopters of against the rule astigmatism. I start thinking of toric IOLs. They're permanent, predictable. They correct astigmatism at the time of cataract surgery, but you have to have accurate alignment. And these are the ones that are available in the United States. We have the Alcon Acria Soft, we have the AMO Technis, The Boston loan gives us an ability to treat lower magnitudes of astigmatism as low as 0.9 diopters. And of course, we have the multifocal toric IOLs in the different platforms. So why do I choose toric IOLs, and how do I make sure that I get good outcomes? And it's really based on two specific aspects. You know, and the other point is that only about 10% of people actually utilize toric IOLs in the United States. But I don't think it's because of outcomes. It's because of, you know, pricing and then making sure to get good outcomes in these patients. So how do I determine corneal astigmatism? There's multiple ways. We don't personally use manual keratometry, but that's reasonable. Automated keratometries like the IOL Master 700 and corneal topography. And it's important to remember that you want things to make sense between devices, and that the area sampled varies with the instruments. So for me, we're very lucky we have the IOL Master 700 and the LensStar. And in terms of topographers, we have the Galilei, we have the Cassini, and the Atlas. And so I look at least two topographers and tomographers and one of the biometers. And if there's more than about 0.75 diopters magnitude difference or more than 15 degrees, then I don't put a toric lens and then deal with the astigmatism postoperatively unless I can understand why. I believe it's important to do topography on all patients that you're going to do toric IOLs. We do it for all our cataract patients. It's important because you want to rule out corneal pathology, ocular surface disease, Saltzman's, EBMD. Sometimes these things can be missed on clinical exam. I love printing out the Placido ring topographer in the Galilei specifically, looking for the rings and the crispness of it. For example, this is a patient that was sent to me for cataract surgery, and they were 20/50. When I looked at the topography, you could see areas of irregularity. If I had just done the biometer, I could have treated for 2 diopters of astigmatism, but this patient actually had EBMD, post superficial keratectomy and epithelial debridement. The diopters of astigmatism decreased significantly, and now you can see it's very regular, and this just shows the difference map between the magnitude of astigmatism. And then it's also important to do topography to evaluate the quantity and quality of astigmatism to place the toric or multifocal IOL, making sure that you're not going to capture keratoconus. And again, all of that can be missed with the IOL Master or LensStar only. So is the posterior corneal astigmatism important? We know from our landmark study from Baylor where we work, is that if you look at anterior corneal measurements, so all of these topographers that only do anterior corneal measurements, you can overcorrect with the rule and then undercorrect against the rule patients. What I wanted to show you from the study is even though we say it's average of between 0.3 to 0.5, it can be as high as 0.8 diopters with the rule and as high as 0.5 diopters. And again, so ignoring this posterior cornea leads to inaccuracies in the total corneal power and astigmatism estimation. And total corneal power is really important for accurate lens calculations. One study showed that one major cause of unexpected refractive cylinder after toric IOL implantation is the incorrect estimation of total corneal astigmatism. So how do you pick the correct toric power? Now there's all of these calculators that include having the Barrett normogram in them, whether it's the Technis or the Alcon, and you can look at the Ascaris calculator. You know, it's important to remember that these normograms kind of take an average of posterior corneal astigmatism by predicting the total corneal astigmatism based on mathematics and population studies. So it's not an actual true measurement. Of course, things like the Galilei and other tomographers and the IOL Master 700 now can directly measure the total keratometry, specifically in the IOL Master by combining telecentric 3-zone keratometry, and it's really important in patients that have large amounts of astigmatism and status post LASIK eyes. So in terms of recommendations, look at multiple preoperative data points for magnitude and alignment, account for posterior corneal astigmatism, account for against the rule. So for some patients, I leave a little bit with the rule. Most of the time, I try to treat it completely. But if it's a young patient, I can consider this. And then we've done some studies to show that surgically induced astigmatism is truly minimal. And then, the second most important point is properly aligning this IOL. As we know, there's ocular rotation when a patient goes from upright to supine, and it can be greater than 10 degrees. And if you don't properly align the IOL, and if you're more than 30 degrees off, you're actually inducing astigmatism, not just not correcting it. And there are 3 different points where you can have these error: reference axis, alignment axis, and IOL alignment. So, there's freehand methods, and then there's automated ways of doing the reference axis, and then intraoperatively marking the steep corneal meridian. So, some of these technologies which we can automate for all of these things are the Zeiss Callista, which we have, the Alcon Varian, which our VA has, and then utilizing the Alcon Aura, for example. And I'm just, in terms of time, I'm just going to do kind of a quick overview. So the Zeiss Callista, you can have.
We have 5 minutes to reach. So
okay.
we try. I hope so that you will give me a time to discuss, hopefully, before Mazen starting.
Okay, no problem. So I'll do quickly, basically, the biometry with the reference imaging. And in different studies, the Zeiss shows decreased post-op IOL alignment and intraoperative alignment. And then same with other studies that show decreasing deviation. Now we have a 3D visualization. It's very similar to the Alcon Varian system, and again, shows decreased toric IOL alignment. Of course, it's important to take into consideration the price of these. Yes, they're nice, but not necessarily necessary to do great outcomes. We also have that Ingenuity, and really, I'll touch base on the Aura. It's nice because it's an intraoperative wavefront aberrometer that measures refraction after the IOL is implanted. I did want to touch base that doing manual AKs is a reasonable option in lower diopters of astigmatism, even though the outcomes can be a little bit more difficult. And I love doing femtosecond penetrating and intrastromal incisions. It's more precise. Recently been doing much more intrastromal. We have the Catalyst laser system, utilize this normogram by Julian Stevens. And we actually did a study that we looked at all of these intrastromal incisions that we had in 77 eyes. And what we noticed was the depth of the midpoint incision was actually more anterior. So because the OCT doesn't measure it right before we do the incisions, I think there's some patient movement, which means we can potentially not treat as much as we want. So, what's really important for these patients, we rule out corneal pathology and irregular astigmatism, and determine the correct magnitude of astigmatism, making sure everything kind of works with the different machines. Developing a normogram is what we're doing right now. We're comparing intrastromal versus penetrating, and then assessing the long-term effect. I utilize intrastromal incisions for less than 1.25 diopters of astigmatism for with the rule, but I actually use toric astigmatism for all other patients. I don't like doing intrastromal incisions for against the rule because of where my wound location is. So in conclusion, and I did this very quickly, toric IOL outcomes depend on really accurate corneal astigmatism measurement, accurate marking of corneal meridians, and using monofocals is a reasonable option in irregular corneas. And I like using intrastromal incisions in some of these patients.
Great, thanks, Zina, for an excellent presentation. Only one question that I can ask, 5 minutes, and I'm sorry that the 2 other colleagues, we don't have time for them. You mentioned that the mathematics consideration for posterior power, posterior corneal power that present in Barrett toric, as we know. So how you are overcoming sometimes that, as you say, that it's not as all the time is inaccurate for 0.5 diopter over, 0.5 diopter under, for with the rule under and for against the rule over. So what you are doing to consider the total corneal power as a part of the Barrett calculation? 5 minutes. Okay,
yeah,
my dear.
So sure. Yeah, so a couple of things. We have the Galilei, which also measures total corneal power.
Okay.
And then we have the IOL Master 700 that also measures total corneal power.
Yeah.
So I look at those 2 things, so that helps with comparisons of if you take the anterior corneal measurements and put them into those calculators and see if things happen. Really, we're not excellent at measuring any of those, right?
Exactly.
We don't have a perfect way to measure
right.
total corneal power.
Absolutely.
So if things don't make sense, right? If it's a young patient that has against the rule astigmatism, or, because that study that was done, it showed that most patients have, with the rule astigmatism that turns into against the rule over time. So things that patients that don't fit into that.
Now you are talking about access, because I'm talking about the power. Because that's another subject. So let us keep on the power side, because access is a different issues. Because Barrett is showing exactly as what you are saying, but the power. Keep us on the power.
Sure. So the power. We've looked at different studies to compare if you use total corneal astigmatism versus just in terms of affecting the power. And if you notice, on most patients that aren't post-refractive, for example, and that don't have large amounts of astigmatism, it's a minimal difference in power. So it doesn't change, picking the IOL. The other aspect is obviously, we only have 0.5 diopters of IOL power. So we're not that good in terms of that minimal difference in terms of power. But we do think that there is a potentially, but can be a potential change in power for small amounts, in those outliers. But no, we're not good enough to take that into consideration. So I don't do anything different.
So great, thanks for you. Final, just 2 minutes to mention some things, because it's important. The K reading, that what you are mentioned, the K reading from total power, that if we are using it, we did a comparative study between the IOL Master 700 and the using of the K reading as a K for the Barrett toric. We found the using of the total K reading in the Barrett toric, it's more accurate than the IOL Master 700. So great thanks for you and for your points and for the points of the axis, because it's very important, especially in young. I'm not using it and I'm not following it. Yes, Dr. Mazen. We reached to Dr. Mazen and 1 minute with us, and Dr. Mazen will talk about issues related to aspheric versus spheric. Right. I don't know whether he liked the aspheric or not. Yes, Dr. Mazen.
I like everything. Thank you, Dr. Safwan. Okay. Assalamu alaikum, everybody. Now, actually, the decision whether to use the spheric or aspheric lens depends on 3 pillars. The first one is the amount and type of the high-order aberrations that the patient may suffer from. The second pillar is the amount and type of the spherical aberration, whether it is positive or negative. And the third pillar is patient's demands, whether the patients would like to have depth of focus to read better, or the patient is concerned about the quality of vision. He would like to have a sharp vision rather than depth of focus. All right. Now, to understand how we choose the spheric or aspheric, we have to know that the cornea has asphericity. Our corneas are aspheric. Now, when the cornea has an asphericity, a specific asphericity, indicated by Q value, which is minus 0.53, this cornea doesn't have spherical aberration, doesn't induce spherical aberration. Otherwise, the cornea may induce positive or may induce negative spherical aberration. And here we come to this. Yes, this one. The spherical aberrations can be divided into 3 categories. The toxic, the non-toxic, and the tolerable. And of course, our cornea, the human cornea, is in the positive direction. Okay, now, if we are looking for depth of focus, it means that the spherical aberration will be more. But this will affect the contrast sensitivity, because the more the spherical aberration in both directions, the less the contrast sensitivity and the less the quality of vision. And at the same time, the more the dysphotopsia that the patient may suffer from. Okay, so as I said, if the patient looks for depth of focus, this will be on the account of quality of vision, contrast sensitivity. And the more depth of focus that the patient may need, then the more dysphotopsia the patient may suffer from. So again, the pillars are the amount of high order aberrations, the amount and type of spherical aberration, and patient's demands. Okay, what types of IOLs that we have in the market? We have the old type spheric, and the aspheric, and the premium. Of course, now we are talking about the spheric versus aspheric, not about the premium. Now, the old spherical type induces positive spherical aberration of about plus 0.15 microns, while the aspherical types are of three types, either zero spherical aberration, so they are neutral, or they induce negative spherical aberration, either minus 0.20 microns or minus 0.27 microns.
25.
Okay. Now, the decision pillars are: convert the toxic spherical aberration into non-toxic spherical aberration. This is rule number one. Maintain the non-toxic spherical aberration if the patient would like to have depth of focus, or push the spherical aberration to be as close as plus 0.1 microns of spherical aberration to achieve sharp vision if he is not interested in depth of focus. I'll give you examples. So this is the flow chart. If the high order aberrations are normal or abnormal, but on account of spherical aberration, or abnormal, but on account of other high order aberrations. So if the higher order aberrations are normal, then if the patient is interested in depth of focus, we have to go for premium IOLs. If image quality is critical to the patient, then we may use negative spherical aberration, because we know that our corneas induce positive spherical aberration, or maybe neutral, zero spherical aberration, if the spherical aberration is near the target, which is plus 0.1. Now, if the spherical aberration are abnormal, but not on the account of spherical aberration, then either we use EDOF, okay, because it is more forgiving than the trifocal or multifocal, if the patient would like to have depth of focus, or if we want to maintain a good quality of vision, then it should be neutral. We should not interfere with the spherical aberration of the patient. And if the high order aberrations are abnormal on account of spherical aberration, then in this case, we have to look why the patient has this spherical aberration, high spherical aberration. Maybe he had previous hyperopic laser vision correction or myopic laser vision correction, and very rarely they are virgin eyes, not operated eyes. So if the patient had prior hyperopic laser vision correction, of course, this patient is suffering from negative spherical aberration. So for sure, we are not going to add more negative spherical aberration. We are not going to use the aspheric types. Either we use the positive spherical aberration to neutralize the toxic, or the zero spherical aberration to keep the non-toxic spherical aberration for depth of focus. And if the patient had prior laser vision correction, myopic one, then of course this patient is suffering from positive spherical aberration. In this case, if these spherical aberration are non-toxic and we want to maintain the depth of focus that this patient has, then either we use the zero spherical aberration or EDOF, or we use the negative spherical aberration if the image quality is the top priority of the patient. And for the toxic positive spherical aberration, of course, we have to neutralize, so we have to use the aspheric, negative aspheric spherical IOLs. We come to the virgin cornea. Yeah, I'm going to finish, Dr. Safwan.
No, it's okay. We have now we have around 9 minutes.
Good. Now, if the patient has virgin eyes, then if it is non-toxic spherical aberration and the patient is interested in depth of focus, then we have to maintain it by using the zero spherical aberration, or we can augment it by EDOF. And if the patient is interested in quality of vision rather than depth of focus, we have to neutralize by using the negative spherical aberration. So at the same time, if it is toxic, virgin eyes toxic, this is, I think, theoretical, but however, I include it here. Of course, we have to reduce this toxic spherical aberration to be non-toxic spherical aberration, and the non-toxic spherical aberration will offer a very good depth of focus to that patient. So as you see, if we want to achieve some depth of focus, we can get the benefit of the spherical aberration that the patient has, not to neutralize the spherical aberration, and not to interfere at the same time if the patient has high order aberrations, for example, of other types. And this is one of the examples. This is the patient has total RMS of 1.2, which is very high, and the spherical aberration is in the non-toxic range, which is 0.58.
Yes.
All right. Mm-hmm. So, and other high order aberrations are high. So there is horizontal comma, which is minus 0.79, mm-hmm. and horizontal trefoil, which is 0.45, vertical trefoil, which is minus 0.42. Okay, so in this case, I would say, let us use a neutralized lens, okay, aspheric, with zero spherical aberration, rather than with playing with the spherical aberration that the patient has, because other high order aberrations are relatively high. This is another example. The total RMS is 0.34, but very obviously it is on the account of spherical aberration, which is 0.31. So in this case, if the patient is interested in depth of focus, of course, we can use premium IOLs, including the EDOF, of course. And if the image quality is critical to the patient, then we have to neutralize this plus 0.31 microns of spherical aberration by minus 0.20. Why minus 0.20? Because this will bring the spherical aberration of the patient very close to the plus 0.1 microns. And if we use the minus 0.27 microns aspheric lens, then it will be less than this. So it is better to keep it as close as this one, because it has been proven that it is the best number that gives the sharpest vision to the patient. And as a take-home message, the decision depends on the amount and type of high-order aberrations, the amount and type of the spherical aberration, and on patient's demands. And thank you very much.
Great, thanks, Dr. Mazen. It was a very academic, comprehensive presentation for the asphericity and sphericity. But one question, I have 5 minutes for that question. What do you think, or what do you prefer to increase the depth of focus of patients with a negative spherical aberration or positive spherical aberration? If you need to, or if the patient need to have an extended depth of focus, what do you prefer? And this prefer or this preference will be in a favor of the patient.
Yeah, of course. Now, actually, both positive and negative, they induce depth of focus.
Yes,
but
exactly.
it has, but usually patients are more comfortable with the negative one.
Yes, exactly.
This is why patients after hypermetropia are more comfortable for near vision than those after myopia.
Exactly.
Okay, it is not only because of the accommodation after myopia, but it is because of the positive spherical aberration induced, although they have depth of focus, but it is not that efficient depth of focus.
Exactly. Great. Thanks for you. I think that we reached to the end of this session. What's a remarkable, fabulous session. I think that the talk was remarkable in a way that it covered a lot of issues. That's right, that we don't have enough time for a discussion, because it needs more than 1 hour or 1.5 hours. But I need to congratulate all the speakers for this nice presentation and for our panels. And we need to close this session because Dr. Barsam is with us and he's looking to me saying, please let us finish and let us start. So Dr. Barsam, we will give you the second the session 2 minutes or 3 minutes before the time. Great, thanks for you. And I need to thank all our speakers and all our audience for nice presentation and for their attendance. Great, thanks.
Thank you. Thank you very much all.
Thank you.
Bye.
Thank you. Bye-bye.
Bye, Zee. Bye. Bye, Dr. Ashraf. Bye, Dr. Osama. Yes, Dr. Barsam, you are mute. You are still mute.
Hi there.
Yes.
I can start my talk now?
Yes, my dear, please.
Thank you very much, and thank you for inviting me to speak. I'm going to talk to you today about when the trifocal IOL is not the answer in the context of cataract or refractive lens exchange surgery. Let me just advance my screen here. These are my disclosures. I am a consultant for Rayner. So I'll talk about some contraindications to trifocal intraocular lens use, situations when most people would feel it's not appropriate to use a trifocal lens. I'll talk briefly about other options in patients who are seeking spectacle independence. And I will talk about my own personal experience with the newest offering from Rayner, which is the Ray 1 EMV, which stands for Enhanced Monovision lens. And it does lead on quite nicely from some of the previous talks with regards to the benefits of spherical aberration induction. So I think that the realm of presbyopia correction or near vision correction is potentially underestimated in our new world. There's a fantastic article published by Steve Dell 5 years ago in Cataract and Refractive Surgery Today, which he titled "All Hail the Near King," and really was talking about all of the differences that exist in society now, which make near vision so much more important than it ever was before. People used to talk about fighter pilot vision, whereas now people are controlling drones from a screen. Everyone's on their mobile devices. The working distance is much less. Computers have become totally ubiquitous. There are, driverless cars probably around the corner. And so the ability to see at far vision is probably less important to patients now than the ability to see up close. So I think presbyopia correction is really essential. Contact lenses and glasses have their own problems, especially in the pandemic when people are wearing glasses and suffering from mask fog. So the beauty of trifocal lenses compared to the previous generation of multifocal lenses, which were bifocal, is that it concentrates some light energy in the intermediate range, which accounts for more natural vision and allows people to have unaided intermediate vision as well as distance and near. However, it does come at a sacrifice, which is quality of vision. This is a kind representation of the night vision problems that a trifocal lens may encounter, but a more realistic example is probably something like this. Now, most patients will adapt to it, and providing they're appropriately selected, remain really happy. So I use trifocal lenses often, and I feel like they are a good option, but they're not a good option for everyone. And the things that we need to attend to with respect to our selection of patients and also our management of patients afterwards, I call the 7 C's, which is to make sure that there is no corneal or ocular surface disease. If there's cylinder present, it has to be treated either with toric lenses or on the cornea with astigmatic limbo-relaxing incisions or LASIK. If they get capsular opacification, there's a low threshold for treating that. Any macular problems are a contraindication to trifocal lenses. Patients generally prefer to have it done in both eyes, and they need a lot of chair time so they can understand and explain, have explained to them what is involved and how long it will take them to adjust. So who do we avoid? Well, those who demand spectacle independence all of the time and who will not allow for any option that they might need glasses. They have unrealistically high expectations. Ocular surface disease that can't be treated, irregular corneal astigmatism, and I would include the older profile LASIK. So I'll look at topographies in these patients, and if the corneal topography looks relatively normal, then it's okay. But most people that had laser vision correction more than 15 years ago, they do have an irregular corneal profile, and I would rather not use a trifocal lens on them. Macular pathology, so every patient gets an OCT examination before, and if they have epiretinal membrane or AMD, that can be a problem. You can treat diabetics, but again, if there's diabetic retinopathy or maculopathy, you may be more reluctant to put a trifocal lens in case they end up with macular problems. High corneal astigmatism. So even if the astigmatism is regular on the cornea, if you accept that there may be a 5 or 10% misalignment of a toric intraocular lens, you're going to lose 30% of the effect of the astigmatic correction, which if you're treating 1.5 or 2 diopters of corneal astigmatism may not be a problem. But if you're treating 4, 5, or 6 diopters of corneal astigmatism, they're going to be left with 1.5 diopters of astigmatism, which is difficult to correct, and it will induce coma. So I prefer not to use trifocal toric lenses in high astigmatism. And then where there are concerns over IOL centration, because of the distance dominant central portion of these lenses, they're very sensitive to decentration. So if you have a patient with pseudoexfoliation syndrome, probably less likely to want to use a trifocal lens. Glaucoma, optic nerve defect, problems with visual field defect is also a contraindication, as is corneal disease such as Fuchs. So what can you use instead? Well, extended depth of focus lenses have become more popular. But the thing about most extended depth of focus lenses is that they really are also trifocal or multifocal type lenses. They just do it with less power. They still, most of them use diffractive optics. They still cause many of the aberrations that we heard about with trifocals, only without the spectacle independence. So they may be, some of them may be less aberrating, but they also give you less vision, and they don't totally avoid the problems that I've just mentioned. So many of the exclusion criteria for trifocal lenses, most of us would also apply to the more traditional extended depth of focus lenses. The Symphony was one of the first on the market, but there are many more available now. So it does leave quite a lot of patients that might want spectacle independence, and where you're thinking to yourself, how can I achieve this? I don't want to use a trifocal lens. I want to use an extended depth of focus lens. What will I use? Well, laser vision correction has been looking at monovision for many years, and it works really well. The most modern profiles, such as Presbymax or Presbeyond, will deliberately induce some level of spherical aberration. And the benefit of that is that you shorten the intermediate area where you may not be treating the vision. So you have dominant eye targeted for distance vision, non-dominant eye targeted for reading vision. And then in order for the patient to perceive natural vision, you want to drive some intermediate vision in, and spherical aberration, which increases the depth of focus, can achieve that. So you're allowing patients to have comfortable vision at a range of visions. But this is obviously, well, until now, this was not an option for intraocular lens patients. Now, what are the advantages of monovision? Well, it's cheap. It's reversible. When I say reversible, if you have an unhappy trifocal lens patient and you've done all the things you're supposed to do, your only option may be a lens exchange, which is difficult and not without risk. If you have an unhappy monovision patient, you could just do myopic LASIK on the non-dominant eye, which is a much easier fix or solution than a lens exchange. Or you could put a Sulcaflex supplementary piggyback lens in, but essentially it's easy to reverse myopia in a non-dominant eye, quite difficult to reverse trifocality or extended depth of focus of patients having a problem. And it's forgiving of other ocular pathologies. Again, if a patient was to develop more problems like diabetes, you probably wouldn't worry as much about it because there are options to improve. Also, if they're struggling with night vision, they can just put glasses on when they drive at night and bring the non-dominant eye into play. So there's easier fixes for any quality of vision issues that they may be complaining of, and it's independent of pupil size. But the disadvantages, it's dependent on the extent of the monovision target. So if you try and drive too much monovision into the non-dominant eye, they may feel disparity and complain of loss of stereopsis, anisometropia or anisoconia, and there can be loss of the intermediate range. And also patient acceptance isn't always good with this. They don't like the idea of having two eyes treated in two different ways. So those are things to bear in mind. Now, we have an increasing understanding of the higher order aberrations and the pros and cons of them. I use Schwind for all of my laser vision correction, and they actually do a dioptric conversion of the root mean square amount in microns to what it would be roughly considered to be in diopters. So you can look at the amount of spherical aberration a patient has before and after. And it's amazing how much spherical aberration patients actually tolerate. Many people have it naturally. They don't complain about it. And when it's induced surgically through laser vision correction profiles, they benefit from it because of the improvement in depth of focus and spectacle independence. So the way spherical aberration works is it just handles light differently in different areas of the optical system, which is what allows you to have the greater depth of focus. Positive spherical aberration will cause more focusing of light in front of the retina in the mid-peripheral areas. And the newest lens available to do this is the Rayner Ray 1 EMV lens, which is, for any of you that are familiar with the C-Flex or Superflex lens, they're kind of hydrophilic monofocal lens. It is identical, it's preloaded, it's a C-loop haptic, and the difference with this lens compared to the standard monofocal lens is that it induces approximately 0.25 diopters of positive spherical aberration, but it results in a significant increase in depth of focus. So I did the first implantation in the world in June of last year, and I've done over 100 implantations since then. This has become the lens that I use in the majority of my patients. And I'm going to present my results in the first 24 eyes that I treated. So these are 10 patients looking at binocular results, and these are the cumulative Snellen and N-type visual results for these first unselected patients. And what you can see is this is not a lens that guarantees unaided vision at reading, and we don't promise that or explain that to them before, but it's highly predictable to achieve intermediate vision and independence of glasses for many close tasks, things like the phone, computer, the watch, the dashboard of the car, seeing to shave or put on makeup, not small print reading. However, it doesn't cause any of the dysphotopsias that you get with trifocal or extended depth of focus lenses.
But Sam, we have 2 minutes more.
Fine. So you can see here that everyone binocularly had N8 vision or better, and everyone had 6/6 vision for distance or better. These are the unaided distance vision results. So again, everyone better than 6/9. This is monocular now, so 22 eyes monocular. Always it's worse monocular than binocular. But most patients were 6/6 or better, which is 20/20 equivalent. And again, monocularly, everyone was better than N12, almost everyone better than N10, and the majority better than N8. It's accurate, as you'd expect. The Rayner lenses are very carefully manufactured and tested. This is an example of a patient that wanted monovision. So in the previous results, I was aiming for predominantly emmetropia in all eyes because I wanted to know how much depth of focus the lens would induce. But it's very forgiving for monovision because of the spherical aberration. So if you do want total spectacle independence and you aim for more myopia, in this case, we aimed for -1.2 in the non-dominant eye, binocularly patient 6/4, N4. What I'm now doing in most patients is plano in the dominant eye and about -0.37, so between -0.25 and -0.5 in the non-dominant eye. And patients are predominantly independent of glasses for most tasks. And I haven't had a single patient complain of dysphotopsia, night vision problems, the need for IOL exchange. I feel that this lens is a game-changing lens for people that want to give patients a premium option without sacrificing quality of vision. So hopefully now we have time for questions. That's my email if anyone wants it or needs it.
Thank you, Dr. Barsam. I think that I start with the Rayner Friday. It was the Rayner that we presented in the live surgery. Hopefully that we will, because I'm old user for the Rayner, before starting with the extended depth of focus. I need to thank you and to end this session with grateful for all speakers and for all our audience to attend this session. Great thanks for all. Great thanks, Dr. Barsam.
Thank you for having me. Thank you.
Also, thank you. Bye.
Bye-bye.
Thank you very much. Thank you.
Bye. Bye, Dr. Mazen. Bye, Dr. Nancy. We will meet you within, I think that 15 minutes or 5 minutes. 5 minutes. Thank you.